How many pieces? Do you
Okay, good afternoon. 20 plus 2.
The name is fine.
Okay, sure. Sister Rica, which I can do.
Sister Ria.
Yeah. Okay. Right, this was the introduction. Then, as an introduction, firstly, let me polite and greet everybody who has attended here. We see the attendance is so good. I like this attendance. My name is DT Mahapa. I'm a urogynecologist here in Polokwane, and my contact details are as depicted on the screen. The topic for today is cesarean section, step by step. The cesarean section, a very old operation that there are many stories about the origin of this term, cesarean section. If you read literature, the book talking about the cesarean section will tell you that the name comes from this, but in essence, it came from the two Latin words, which is called cedo, which is to cut, and sectum, which is also is to cut, which means if you look at this word, this phrase is a phrase of two words with the same meaning, two Latin words with the same meaning. But the literature has got so many stories about the origin of cesarean section that you don't know which one to believe. One that has permeated the literature too much and is known is one that was told by a man called Pliny. He told so many lies in history, such that they called him a lying historian. Pliny said that cesarean section is called cesarean section because Julius Caesar was born through cesarean section, which is not true. Before Julius Caesar was born, long before cesarean section was done. So it can't be true, but this is what most books will tell you. It's not true. That's what Pliny, the lying historian, has told the people and told the world. And because by the time Julius Caesar was born, you know the word Caesar, the Roman emperors were called the Caesars. Even long before the birth of Jesus Christ, the Roman emperors were called the Caesars. That's why Caesar, when he was ruling in Rome, which the time Rome and Spain were one, and Pontius Pilate was the governor in Judea. Caesar was in Rome. So in by the time of the birth of Jesus, cesarean section, nobody knows cesarean section. And now that's why after the people taken from Pliny, people who were born from cesarean section were called Caesons because they were born out of cutting. One book of Pliny, it depicts this picture as a picture of a child being born of cesarean section. A child can't be born of cesarean section and look so big. A child who is born of cesarean section is small as a tiny newborn. So it means that Pliny was just a historian, and as the name say, he was a lying historian. So there are so many lies about the origin of this. Don't know what to believe where the origin is, but my Latin explanation it's a phrase that comes from two words, Caesar and cut. All two words they mean cutting. In the year 120 and 1115 after the birth of Christ, history, the first Caesar that was recorded was a post-mortem Caesar, which means the mother died probably in a war, and then they produce a child. And they say that these three people who are very famous, most of history is taken from religion. Religion is the Bible and theology is the oldest history recorded. The man called Conrad, who was the Bishop of Constance, and baby of Saint Paul, were all delivered by Caesarean section. Conrad was born in 1909, 909 years after the birth of Christ. And the other one was, baby was born 949. And they were born prematurely, cut in the abdomen. And they were both intubated in a dead pig's body. They will kill a pig. Before the pig gets rotten, they put the child inside it because the meat of a pig becomes hot for a long time. There were no incubators at that time. And somewhere during a war, I'm sure a dagger or anything penetrated an abdomen, pregnant abdomen. The head protruded from there. And one of the noble soldiers, one of the brave men, delivered a child called Sancho. This Sancho grew up to become the king of Navarre around the 12th century. Another history about Caesarean section, these are children born by cutting the abdomen and taking out the baby. Unlike now, we plan it. That one is just explaining how baby been taken out of the abdomen. About 15,000 years ago, at the year 15,000, which means 1,500 years after the birth of Christ, the man called Mufe, who was a pig gelter. What is a gelter? A pig gelter is somebody who castrates pigs. A gelter is a castrator. Even in the village here, we always have a man who castrates the cattle, who castrates sheep. That man is a gelter. He was a pig gelter who was very famous. His wife went into labor and had a very difficult, prolonged labor. He cut his wife and delivered the baby. Luckily, it is by luck, because this girl was not even a doctor, and by then there were no much antibiotics, there was no anesthetic. I don't think this baby was under anesthetic. They both survived, the child and the baby. How the method was done, whether it's stitched, how much bleeding he had, it's not told. Because Caesarean sections, how were done, were up and down. You cut from the sternum downwards and take out the baby. Not even suture the uterus. But nowadays with technology, we go layer by layer. We cut, we know which layer to layer. When you come back, we're going to suture that particular layer. Previously, they used just to go and take out the baby, not suture all the layers. You'll heal by secondary union. You heal, you are lucky. You die, well, you die. My majority of people previously in the operations, they died because of delivery of a baby through a cesarean section. Commonly, it would be like where the baby, the mother has got a difficult labor. In Africa, especially here in Limpopo, I'll talk about the Leboa area. There's a terminology that says that Musadi she died during delivery, probably during pelvic disproportion, or she died because of a bleeding, ruptured uterus, bleeding inside. So I assume that many women that time were by because nowadays cesarean section is very easy, anesthesia is easy, antibiotics are well advanced. There's no reason for Musadi or Jekin. Previously, it was very common for Musadi So we, let me advance here. What are the types of cesarean sections that we have? We've got many types of cesarean sections. The definition, firstly, as I've tried to explain the origin of the name, is usually known as C-section or cesarean delivery, which is a surgical procedure used to deliver a viable baby. Why I stress the word viable? That baby must be at least 28 completed weeks. That pregnancy must be more than 28 weeks. If the pregnancy is below 28 weeks and is delivered by operation, it's not a cesarean section. Cesarean section is only a surgical procedure involving cutting in the abdomen, incision in the abdomen, on the abdominal wall, deliver the baby from the uterus. That pregnancy must be 28 weeks and older. If it happens that a surgery or an operation has to be done to deliver a baby of less than 28 weeks, that operation is not called cesarean section. That baby is not viable. It's called hysterotomy. Hysterotomy means just making an opening in the uterus and taking out the baby. Because if that baby was to be born normally, it wouldn't be a birth, it would be an abortion or miscarriage. If an incision is done on the abdomen to deliver a non-viable baby, less than 28 weeks, it's called hysterotomy. So you find people saying that I had a Caesar, but the baby didn't alive. But say, how many weeks were you pregnant? It is, I was 25 weeks. That's not a Caesar. A Caesar is only meant for a viable baby. Different types of Caesars. You can divide it according to the timing. When do you do a Caesar? That's what you call elective cesarean section. Elective cesarean section is a planned cesarean section. It's decided during pregnancy. During pregnancy, it's decided that the delivery will be by cesarean section for a proper reason or indication. If there's a reason that you've had previous myomectomy, you have had previous surgery, or the baby is too big, or the pelvis is too small, and during pregnancy, it's decided that you will deliver by cesarean section. That's an elective cesarean section. There's another one which is called emergency cesarean section. Emergency cesarean section, during labor, which is intended to deliver vaginally, some complication arises. It might be maternal complication or fetal complication that necessitate that delivery must be done quickly. The benefit of the baby or the mother, you have to expedite delivery very quickly, which means vaginal delivery is not imminent at that moment. For example, if the baby gets tired, what you call fetal distress, you see the fetal heart rate goes down, or the baby passes the feces inside the uterus early in labor, such that you think if you can prolong labor, he might aspirate the feces, or the mother get exhausted. There are many reasons. Then it becomes an emergency. Or during the labor, it's discovered that the baby is too big to pass through this pelvis. Then it is what you call cephalopelvic disproportion. Then it becomes what you call an emergency cesarean section. One should know what kind of cesarean section she had, emergency or elective. If it's elective, answers that what you have done Caesar for is a recurring cause, which means the other pregnancy also, the cause of Caesar might recur, might also be there. But if it's an emergency, some of the reasons for emergency Caesar are not recurring. Some are recurring. Like, for example, if the pelvis is too small, cephalopelvic proportion will always recur in the second pregnancy, because usually subsequent babies in weight, they are bigger than the first babies, because now the mother is well matured, the baby's socioeconomic status has improved. Subsequent babies are firstborns, secondborns are always bigger than secondborns in weight. You can divide them again further into two types, according to the type of incision that you make on the uterus, on the body. It might be lower segment cesarean section, which means you did it on the lower segment of the uterus. The uterus has got an upper segment and the lower segment. You can do on the upper segment, depending on the indications. Although I must state that majority of cesarean section these days are done on the lower segment, but there might be a reason that compels the doctor to do it on the upper segment. Like, for example, if there's a tumor sitting on the lower segment, or a lot of vessels sitting on the lower segment, or another common thing, patient who has had renal transplant, because when they transplant the kidney, they put it in the pelvis, and there would be a lot of blood vessels there, uniform, is dilated, there in the lower segment. So you have to run away from them and do an upper segment cesarean section. The upper segment cesarean section, I'll describe them now. The lower segment cesarean, they differ. The incision of the lower segment cesarean section is made about 3 centimeters above the symphysis, about the pubic symphysis. And the incision of the upper segment cesarean section are far above and extend below the umbilicus, from the symphysis longitudinally below the umbilicus. And in the blood loss, lower segment cesarean section, less blood loss, because the lower segment is formed, the muscles are not very thin, and the blood flow in the muscles are not, it doesn't bleed much. In the upper segment of the uterus is usually thick, with thick muscles, and it bleeds a lot. The lower segment heals very well. Most people with a well-formed lower segment, it heals very well, such that you can even repeat after cesarean section with the lower segment. You can deliver vaginally the next delivery. But if it's the upper segment, the healing is not very good. It's not advisable that the next pregnancy you must try to deliver vaginally. If a woman has had a Caesar, and the next pregnancy they want to deliver vaginally, that's what you call a trial of scar. They are trying that scar, which is a very dangerous thing and a dangerous nomenclature. The best one that I like to say is VBAC, vaginal birth after cesarean section. You try it. Only do it if a patient has had lower segment cesarean section. So it's important that when you've done a Caesar, you ask what type of incision was done on my uterus, so that next pregnancy should not attend at the same doctor. You must tell that I had an upper segment cesarean section, so that the doctor must not attempt for you to try VBAC on you. So most people don't know what kind of scissors they've had, but that information is there and it can be told to them. If you look here, I said the commonest is this is the uterus, this is the upper segment, this is the lower segment. Majority of scissors are done on the lower segment. It's transverse. It might be longitudinal. There's possible that you can do a longitudinal lower segment cesarean section. Or you can do it on the upper segment, where I said the muscles are thick. If it's the upper segment, longitudinal, it's called a classical incision. While this lower segment, which is longitudinal, which sometimes extended slightly into the upper segment, it was first described by a man called DeLee. That's why it's called a DeLee incision, and after the name, the person who described it. So the classical cesarean section, a uterus is cut on the fundus, high up on the fundus, while in DeLee, it's a vertical lower segment incision, as I've shown it, encroaching on the middle part of the uterus, which is thickened. The bleeding in DeLee might be higher than the lower segment transverse incision. Lower segment transverse incision, the uterus is cut on the well-formed lower segment, is curved slightly upwards, so that by the time the baby comes, should the incision extend itself, it shouldn't tear downwards, it should tear upwards, because if it tears downwards, it will go towards the artery that supply, blood vessel that supply the uterus, which is uterine artery. And in that area, there passes also the ureter, which carries the urine. And with bleeding there, suturing a tear which went downwards, one is likely to find the ureter. There's another incision, which is called butterfly incision, which is a straight lower segment incision. like the curve that I described. It's not recommended because if the baby is big and when it comes, the incision extends itself, the lowest portion, the weakest point will be downwards. It will go downwards. There's another one called Munro-Kerr incision, which is a lower segment, which is curved downwards, deliberately curving downwards. I don't know why Munro-Kerr decided to curve downwards, because if this can be extension, the chances of uterine artery damage are very high. And if you try to suture there, the chances of tying the ureter are very high. And thus the chances of cesarean hysterectomy are very high in those cases. There's another one which looks like a trapdoor, which is named after the person who described it, which is called Bailey, which is curved 90 degrees upwards. It might be lateral, it might be one side. That way, it's safer, because if there's any extension, which is unintended extension, it will go upwards and is easy to repair. Brunner described a Y incision and a T incision. T and Y incision are indicated if the lower segment transverse incision becomes too small for the child to come out, and the surgeon has to extend the incision. And going laterally, he thinks he will go too far lateral to go to the uterine artery. He either makes an inverted T or an upright T or a Y incision. That was described by a man called Brunner. These are the type of incisions that I've just described. And if you look at them here, the one, which is lower segment straight incision, it's Druflas incision, which is a straight incision in the lower segment. And then you've got the one that ends slightly upwards, which is Funnel-Steele. Although the Funnel-Steele, when he described this, he described it on this abdominal skin. But inside also, lower segment transverse was propagated by the man called Funnel-Steele. I like this man because I had the opportunity to go and study at the university where Funnel-Steele was the head of the department. He was the head of the department of the University of Obstetrics and Gynecology in Germany. The history that he died very young. He died because during operation, he cut himself and got infected. He died from infection that he contracted during operation. Mind you, by the time, antibiotics were not much strong, and people didn't know actually what causes infection. Semmelweis has just described that infection is caused by pathogens. Bacteria was not yet described, so he died very young, but he contributed a lot. And we see the one that curved backwards, which I said, I don't know why Munro-Kerr did. It's the one that's described by Munro-Kerr. And we've got a lower segment upward incision, which is a Lee incision. The one that curved upwards both, which I say is very good, is the one that is a trapdoor, which is made by Bailey, which I said Bailey. And we've got the Brunner's Y incision or the inverted T incisions, which can be made like this. As you can see here, the trapdoor incision of Bailey. This is a T incision. This one is not an inverted T, it's an upright T incision of Brunner. This is a very rare incision that I made, but they are still made. They may be an indication or a situation where the surgeon has to resort to this type of incisions, although they are not commonly done. The commonly one done is lower segment transverse, which doesn't bleed much. But if you have to do it slightly on the upper segment, it can bleed. But the bleeding of the lower segment is easily controlled by clamps. 1 or 2 clamps you can allow you to suture without losing much blood. And if it's upper segment, when you suture, you can't suture it in one layer because it's thick. You have to go in many layers, and the layers interacting each other or interlocking each other, so that there mustn't be a dead space between your 2 layers. People usually they ask, what kind of incision I'm going to make on my body? Because women want to expose their stomach these days. It's fashionable to expose their stomach of women. If we tell them I'm going to do a midline vertical, they become very unhappy. There are reasons, indications for midline vertical. Those reasons might be from the baby who's too big, or conditions that the baby has, sorry, or to mother, like an obese mother with a panniculus, the lower segment transverse incision like Funnel steel would probably will not heal better. The type of pain that you are going to have with midline vertical incision, pain is less because you don't cut the nerves, you cut between the nerves. And with the transverse incision, one of the things that people complain about is numbness after cesarean section, because as the nerve passes, you cut them, and the nerve end, you lose sensation around the scar. Fortunately, as time goes on, those nerves adapt, the numbness goes away. Or you feel pain because the nerves were cut. Even if they were the sensation for that nerve was for touch, they sense temperature as pain. When it's cold, it becomes painful. But because people like beauty, we resort to that midline many times. The horizontal incisions that are usually done, which are called beginner's incision, is the one that I described by Funnel steel, the one who described the one in the uterus. And there's another one where it's called Maillard incision, where you have to cut the muscles themselves. Maybe it's because the baby is big, or there's a tumor there, or the lie is transverse. But the other one, which is called a Chinese incision. Chinese incision, it doesn't cut the muscles. It transects the muscles at the conjoint tendon, that when the muscles join the bone, to transect that muscles there and later come rejoin it to the bone. These are the type of incisions that you do. The last two is just to increase the ease of the baby coming in, because cesarean section should be easier than normal vaginal delivery. Looking at the body, this midline incision extends from the symphysis pubis towards the umbilicus. But I want to go back. The Maillard incision is highly higher because here, that's the area where you are going to cut the strap muscles, which is rectus abdominis muscles, abdominal muscles, which run longitudinally here. But with Funnel steel, is about 2 finger breadth above the symphysis pubis. Joel Cohen and Funnel steel, more or less the same, except that Joel Cohen is straight. Majority of surgeons that are doing, and gynecologists that are doing, they say they are doing Funnel steel. Go and look, find that it's not a Funnel steel. It's a straight incision. It's usually a Joel Cohen incision, but he says a Funnel steel. Funnel steel should have a curve, and it must be within the hairline, so that when the pubic hair grows, it mustn't be. If you see a Funnel steel coming above the hairline, more often it's straight. Then it's a Joel Cohen incision. It's not a Funnel steel. A Funnel steel will go inside the hairline. The beauty of the Funnel steel is that it's covered. So, in summary, this is the most safe, effective incision. It gives you maximum exposure. Unfortunately, it's the most hated incision by the patient. I don't know who decides which incision must be made. Is it the doctor or the patient? I decide which incision I must make on the patient for the safety of the baby and the mother. But the mother, because of fashion and lay magazine, always wants a Funnel steel. Fortunately, majority of them, they get what they want. I just want to show you what a Maillard incision is.
The landmarks for the Maillard incision are the anterior superior iliac spine on both sides, the umbilicus, and the pubic symphysis. The patient has a scar here, probably due to an appendectomy. The incision length may differ depending on the wanted exposure. it is placed about 5 centimeters above the pubic symphysis in a slightly curved line which runs over the old scar. The borders of the rectus muscle are marked. The skin is incised between these borders. Sharp wound retractors are inserted and the subcutaneous tissue is dissected. Scarpa's fascia is encountered, which is more pronounced in young men and may diminish with age. The anterior rectus sheath is reached, which is incised transversely along the length of the skin incision. Then the rectus muscle is seen. It is transected with scalpel or electrocautery. At this level of rectus muscle, below the arcuate line, there is no posterior rectus sheath. The preperitoneal fat is encountered here. At the lateral border of the rectus muscle, the inferior epigastric vessels can be identified and are ligated. The rectus muscle on the other side is transected as well. Then the peritoneum is grasped with tissue forceps and incised sharply in the midline. The risk of intraperitoneal organs is reduced by grasping and pulling the peritoneum upward with forceps and performing the incision when the silver sign is seen. The silver sign is the reflection of the scissor blade or forceps through the peritoneum.
The initial peritoneal incision is extended in a horizontal direction using scissors.
I just wanted to show you what a malar incision is like. This, as you can see here, the muscles are being cut, but usually with a funnel steel incision, longitudinal incision, you don't cut those muscles. You transect, you separate them. Fortunately, I was trying to separate them. As you separate them, you make sure that they remain intact. There's a line between two strap muscles, which is called linea alba. Linea alba means white line, it's line. Strap muscles extend from the rib cage of the symphysis pubis. So let's tell you what the layers you go through when you cut through a cesarean section. First layer is the skin. And below the skin, you've got a subcutaneous fat, which is formed by two types of fascia. Superficial fascia is called Scarpa's fascia. And as you go down towards the peritoneum, you get campus fascia. After the campus fascia, then you get rectus fascia, which is called rectus sheath, which is a stronger fascia than Scarpa and campus fascia. Actually, that's the fascia that keeps the abdomen together, which is called rectus sheath. It's got two leaves, the posterior leaf and the anterior leaf. The anterior leaf is stronger. It's the one that covers the anterior leaf and the posterior leaf. We covered those strap muscles, which are called rectus abdominis muscles. Then you reach the rectus abdominis muscles, which I said in the modern day, we separate them. But as you have seen there in malar, you have to cut them. And as you cut them, they bleed, muscles would bleed. Then you get posterior leaf of the rectus, which is more thinner. Then you get peritoneal fat, the peritoneum. There are all about 7 layers that you go through. And as you suture back, you must suture all those layers and make sure that you put them anatomically correct. But the abdomen, some abdomens got a thick scapa and emphasis fascia, which is thick subcutaneous fat, which you must go through it. And as you become pregnant, the pregnancy will become more bigger, which means you have to traverse a thicker area before you can reach uterus. That will determine what kind of wound you are going to make. But if you are careful when you suture and you suture each layer by layer, there's no need to have a cosmetically ugly scar. But once you don't suture them properly, scar become very much ugly and uncosmetic. Sometimes if a patient is too, I don't want to say fat, it's got increased body mass index, is a big woman. After cesarean section, the stitches that you use, although they're strong, they're not so strong that can withstand things like heavy cough in a muscles. So you have to use other stitches that are stronger, keep that wound closed. Otherwise, you've got the wound bursting as the patient is trying to lift something, especially when they cough, because after the operation, there's usually a cough. During the operation, there's a tube that the anesthesiologist put on the throat. It might irritate the throat, you cough. And as you cough, you increase the intra-abdominal pressure, wound might burst. So usually we put retention stitches, which might cosmetically make the abdomen ugly, but they are necessary for you to put because you need to have an intact wound that heals very well. What are the indications for cesarean section? There are many reasons why one can have a Caesar. One of the indication is that can be maternal. The mother, the indication might come from the mother, might come from the baby. If it come from the baby, it's called a fetal indication. Like, for example, the presentation of the baby, how the baby is sitting inside the uterus. Normally, or commonly, the baby, the head faces downwards. And when the baby comes out through a normal vaginal birth, it's the head that comes out first. But sometimes the baby might turn around or when the baby is sitting upright, and it's going to be delivered legs and the buttocks first. That's called breech presentation. It's either deliver the buttocks first, the feet first. And if it's the feet first, when the feet came out, the feet are not good dilators of the cervix. Head might not come when the feet has come out. You'll have what you call entrapment of the aftercoming head of the breech. If it does happen, it's such a cruel thing because the only indication that you can deliver that baby is decapitate that baby and take that the baby on the neck. I don't want to see, I've seen it once in my life and I told myself, I'll never do that thing. But if it does happen, it's a calamity. So if it's breech and footling breech, the best thing is to do a cesarean section because you don't want to have entrapment of the aftercoming head of the breech. But another form of presentation, which are called malpresentation, which means abnormal presentation, like the baby transverse lie, it's lying obliquely in the uterus, the presentation is a face, is a brow, it's unstable lie. Today it comes, it's breech, tomorrow it comes, it's transverse, tomorrow it comes, it's an oblique lie. Compound presentation, the way I'll describe what compound is, where two parts present together and they cannot pass through the abdomen. In twin pregnancy, if the first twin is breech, always cesarean section. I'll show you the reason why later when you have got what you call locked twins, where the other twin come out to feed first, and the other twin, the second twin is cephalic. In the head, they lock each other. There's no way you can lock them. They're called locked twins. If the first twin is not cephalic, it must be cephalic, cesarean section. Maternal indication where maternal delivery is not possible. Like, for example, if the baby has got this big, pass through the maternal pelvis, which is small, called cephalopelvic disproportion, which means it's a disproportion between the head of the baby, which is a cephalo, and the pelvis of the mother. Or labor is dangerous for the mother. Like, for example, the mother with a disease that if she goes into labor, she will be dangerous. She, like patient with cardiac diseases who might go into severe cardiac disease, who might go into labor and go into heart failure. Nowadays, with the advent of HIV, it has been proven that vaginal delivery has got a high incidence of vertical transmission, transmitting the virus from the mother to the baby, because what transmits the virus from the mother to the baby is fetal-maternal blood admixture. And during labor, even before the placenta separate, there is mixture of maternal and fetal blood. Elective cesarean section has got a very low risk of vertical transmission, which means transmitting the virus from the mother to the baby. I don't say it doesn't. I say the risk is lower. It's higher in normal vaginal delivery. If you want to reduce the risk, most people will recommend elective cesarean section. If the placenta is lying down such that where the baby must pass, there's a tissue there called placenta, which is called low-lying placenta or placenta previa. Then there's no way the baby can pass. It must be maternal cesarean section. This is a picture of a locked twins. If the first twin is rich and the first twin comes out, and through the chins here, the first and the second twin, they lock. There's no way you can deliver those twins. Even when you do a cesarean section, the first twin, you must take it out to the abdomen. You have to decapitate it. Nobody, I don't think there's any surgeon who wants to do decapitation. Not me. I don't want to do decapitation. First twin breach, elective cesarean section. Because this pelvis, maternal pelvis, is sort of constant. Although there's some few millimeters of dilatation during labor, if the head is too big, it can't pass here. If it is compact presentation, it can't pass through the pelvis. So I should assess whether there's a fetal-pelvic fit. Can the head pass through this bony pelvis? If the head cannot pass here because the baby is big, then you don't want to, if you encounter cephalopelvic disproportion during labor, then it becomes an emergency Caesar. But majority will be detected antenatally that this baby is too big. And then you can plan electively do a Caesar, electively Caesar. With ultrasound, you can measure the distance between the two parietal bones. Usually, if it's 9.5 centimeters or less, in majority of cases, it will fit through normal mother who is of normal height. But if it's a short mother with a contracted pelvis, it will not pass through. But usually this is done ultrasonographic. Previously, we used to do what you call X-ray pelvimetry. It's never done even that. Some people recommend the MRI. It's just expensive. With sauna, you can measure very clearly what's the distance between here and here. And you could do pelvimetry, manual pelvimetry, by putting the finger in the pelvis and measure the distance between the two spinous processes, which is interspinous space. Estimate this can be about 10 centimeters, 9 centimeters, 7 centimeters. You can, with a good experience, you can guess whether there will be they will be able to pass here or she won't be able to pass here. There's no need these days to do expensive maneuvers like MRI, like pelvimetry with X-ray, which radiate the baby. Because X-ray, the problem with it, it's got radiation. It radiates the baby. You don't want to radiate the baby who is in utero, because the bone marrow of the baby is not unlike the bone marrow of an adult. You might just cause some hematological problem in the baby. Majority of indications, maternal indications, easily depicted. Like I've said, pelvic disproportion, cardiomyopathy. There's a pelvic tumor. Like for example, a huge myoma sitting there, which is a uterine tumor, or other pelvic tumor from other organs in the pelvis. It might be from the ovary, might be from the rectum, or might be a body tumor, which compete with space for the baby. But if there is bleeding during pregnancy, and the baby is viable, the best thing is to do an emergency cesarean section, like in abruptio placenta. Abruptio placenta means premature separation of the placenta from the uterine wall. Patients with hypertensive disorders of pregnancy, they tend to have abruptio placenta, they tend to have fitting, which is called eclampsia. They tend to have maternal complication during and after delivery, and they're better if blood pressure is slightly controlled. Once they reach 10, deliver them by cesarean section. For some women during delivery, they just have abnormal uterine action. Uterus doesn't contract very well. Patient with previous uterine scar, I've said that whether it's sterotomy or it's metroplasty. Metroplasty is cutting the uterus in order to correct genital abnormalities of the uterus. Or a cesarean section, which is upper segment, either DeLee or classical cesarean section. That's why it's important for a person to know what incision was made on it, so that you can decide how to deliver in the subsequent pregnancy. One should not do debug or trial of scar in a woman who has had metroplasty or has had hysterectomy, classical cesarean section, or even DeLee incision. If a woman has had what we call this VVF, vaginal fistula, and it's repaired successfully, it's recommended that you must deliver cesarean section. Because if you can force to deliver vaginally, you develop a second VVF. Second VVF is almost impossible to suture it, because area of VVF is always hypovascular, it's poorly supplied with blood. Successfully repaired VVF must always be, a woman must always do cesarean section. I want to tell you about show you the presentation of the baby. Vertex presentation is a normal presentation where the baby is flexed, the occiput is upwards, and the diameter is sub-occipitopregmatic diameter or sub-occipitofrontal diameter. If you too much flex, it will be from the brecma. Brecma is the anterior fontanelle. From the anterior fontanelle to the occiput. That's the diameter, which is more or less 9.5 centimeters or less. But once you can deflect the head in the presentation, it becomes brow. It presents with the largest diameter of about 13 to 13.5 centimeters. From the mentum, which is the chin up to the occiput, which is about 13, and it has to pass through a pelvis of about 10 centimeters. You see, it can't pass there. But if it's face, the diameter is not so big. Sub-occipitopregmatic is not so big. It depends whether it's face to pubis, occiput is to the pubis. If the face is downwards, the occiput is anterior, occipito-anterior face, then the face, because the denominator is not the occiput. Mentum, the denominator is the mentum, is the head. If the mentum is posterior, it's better by cesarean section, because that head doesn't flex very well. If the mentum is anterior, it deflexes very well under the pubis. Deliver. It depends whether it's face to pubis or it's not face to pubis. Not all faces need to deliver by cesarean section. Like you see here, if it's a bridge, if all ankles at the knees, the hip joint, they are flexed, it's called a complete bridge. And a complete bridge can deliver vaginally. It will just be unfortunate if a complete bridge turns into a footling. One foot come out first and the other one is not coming. Then we call it a footling. But with good care, it never converts into a footling. With vertex presentation, that's the commonest that happens. Fortunately, this is the face that I told you that this is mento-anterior. A mento-anterior can deliver very well, but mento-posterior is difficult to deliver, and as the head is very small, because the mentum will hit against the coccyx, will hit against the tailbone of a human being. Mind you, human being has got tail. The last few vertebrae of the human being is called coccyx. It will hit against the coccyx. And the head, when it hit against the coccyx, the upper part of the head will hit against the symphysis pubis. Like face to pubis, it will deliver very easily. If this is forced, the coccyx break, then you're going to have a condition called coccydynia, which can be lifelong. Whenever you sit down, you sit on that broken coccyx, it becomes painful. You don't want to cause coccydynia with the mother because you delivered a anteroposterior face presentation. Sometimes the baby, instead of being longitudinal from downward, it goes transverse obliquely across the mother. Either pushed by a placenta or pushed by a tumor in here or whatever pushes it. It doesn't present, so it oblique will not oblique presented baby will not pass through the vagina very easily. The best thing, if it's constantly oblique, you can't manually change it. The operation that's needed for this is elective cesarean section. But more often you find that it just lies transversely across the abdomen and it can't deliver by the back. And it's transverse, it's constantly transverse. It doesn't change. And look at the amount of amniotic fluid. It doesn't allow you to do external cephalic vision. If it doesn't allow you to do external cephalic vision, you will plan for elective seizure. Mind, I must tell you that external cephalic vision is a very old maneuver that's a bit outdated. It's got many complications because during external cephalic vision, you might be umbilical cord entanglement. Umbilical cord, if it's forming a knot, you might make that knot very tight. If sometimes you don't know what the placenta is, you might cause intended abruptio placenta. Many people will not do it. We mention it just because it can be done, but because Caesar is so safe, anesthesia is so safe, antibiotics are so safe. The other benefits of cesarean section on pelvic floor, later incontinence, it's better to do a cesarean section than to do external cephalic vision. Some people used to do it even for breech. If it's compound presentation, I said, when two things present, here the head is presenting, the hand is also presenting. Both of them will not go through a pelvis at the same time. So compound presentation, cesarean section, because if it's compound like this, the hand is likely to come out first and further pushing the head on the fossa of the pelvis. So the baby will just be injured. You might just break the clavicle or break one of the legs because the hand also occupies space here. And as it occupies space, it increases the diameter, the presented diameter in a compound presentation. So in summary, majority, the good Lord made it that more than 90% of patients will present as cephalic presentation, longitudinal line. For breech presentation, current breech, where there's flexion at the hip and extension at the knee. This can deliver vaginally very easily. But oblique and transverse lie, there's no chance of vaginal delivery. As much as I've said that in mental posterior face presentation, where you can say that this is a face. Only way they can feel it when you do a digital examination is the nation, the nose bone. Don't put in the eyes. You'll nucleate the eye, the nation. You can tell whether it's a face. One of the calamities that might happen during or antenatal or during labor is cord presentation. If membranes are still ruptured, and you do a nice digital exam, you can feel that there's a cord presenting before the head. And if vaginal delivery can occur, it will occlude the blood flow to the baby because blood flow from the mother to the baby goes through the umbilical cord. If the membranes are still intact, it's called cord presentation. Once the membranes are ruptured, it's called cord prolapse. Then it says prolapse, which becomes an emergency. Any cord presentation discovered during antenatally elective seizure. Cord prolapse, if it happens, is an emergency seizure. So in that way, types of breech that I told you that if there's flexion at the knee and there's a flexion at the hip, it's called complete breech. If there's a flexion, one leg is complete breech, one leg there's extension at the knee, it's called incomplete breech. And the complete breech is one which is likely to turn into footling, even incomplete sometimes, but very rarely. Frank bridge is one where there is a flexion at the knee, flexion at the hip, and extension at the knee. This one will never present as a Franklin bridge, and it easily delivered and the other two. So if we've got a bridge during ultrasound, just check what kind of bridge are you having. You're having a complete bridge or you're having a Frank bridge. If it's a Frank bridge, watch out for footling presentation. Footling might force you to do emergency Caesar. I said earlier on that if placenta is low-lying, it's called placenta previa, and you compete for space with the presenting part. And it increases the chances of abnormal lie like that oblique lie and transverse lie. This low-lying placenta or placenta can be complete or incomplete depending how high it is. And one feature of it, this pathognomonic of it, is intermittent bleeding during pregnancy. It bleeds and stops and bleeds and stops, and treatment usually is just conservative. Bed rest and stay, because sex is one of the things that will precipitate, because that husband's hammer will be hitting the lower segment and hitting the area where the placenta is seated, that exacerbating premature separation of the placenta and can even cause rupture placenta. There's a placenta previa with a viable baby and the bleeding occurs, it's emergency cesarean section. There's no need for conservative management or prolongation of pregnancy in a viable baby who has got placenta previa, because you don't know when it's going to bleed to the extent that the babies get examinated, the baby dies. If it's at term, of course, you're planning elective cesarean section. If the placenta is lying here but doesn't cover the internal os, it's low lying, but it goes out to the internal os, placenta previa. If it covers the internal os slightly, but with dilatation, it might move away, or it completely covers the internal os, it's called complete placenta previa. Some people put them in type 1, type 2, type 3, type 4. I like partial or complete, because type 1, type 2, how many centimeters is there? There's no time to measure such things. If you can see the internal os, it's partial. If you can't see you can see the placenta over the internal os, it's complete. The complete, absolute Caesar. Partial, type 1, might just deliver vaginally, might not deliver vaginally. It might separate. If we have to deliver vaginally, must watch out for mature separation as the lower segment is forming and elective Caesar. So this type 1, type 2 can only be tried to deliver vaginally in a situation where theater is available, anesthetic is available, everything is available for emergency cesarean section, if anything happens. But if in a hospital where it takes you 2-3 hours to arrange a Caesar, once you've got placenta previa, I recommend we do a cesarean section. And you can see it very well on ultrasound. If you've got a fetal presenting part, you see the placenta is low lying, and the vagina is going out here, the cervix is going out here, you know that this is a complete placenta previa. It's not partial. So the management, the patient will be told that because the placenta is low lying, we have to do a cesarean section. Commonest one that happens nowadays is fetal macrosomia. Ideally, fetal macrosomia occur in diseases like diabetes mellitus. You also find it in patients who are not diabetic, because now the socioeconomic status is improved. People eat well, and they're lazy when they're pregnant. They don't exercise. Baby becomes so big. Any baby is more than 4 kilograms above, you estimate, it's macrosomic. That baby will never pass through a pelvis of a normal woman, unless a woman has got a very large pelvis. They've got a tendency of having cephalopelvic disproportion. So if the baby is large, treatment is elective Caesar. But if it's macrosomic, exclude diabetes. You won't always find diabetes, but diabetics are the one that usually have macrosomic babies. Macrosomic babies, when the baby becomes big, it's asymmetrical. The head doesn't become very big. It's only the body from the shoulder and the abdomen and the pelvic that becomes big. So if she delivers vaginally, the head will come through, the shoulders won't come through. That's what we call shoulder dystocia. We've got a head that's protruding, the shoulders can't come through because the body is too big. And people tend to do, I've seen it happening, and it's very dangerous. They apply what they call fundal pressure. The midwives will climb on the bed and push, that's injuring either it breaks the clavicle or he injures the brachial plexus, and that's what you call it, palsy. So if the baby is big, the best thing is to do elective Caesar. And diabetes is if there's diabetes, elective Caesar must be as soon as it reaches time, because the very notorious diabetes of having unexplained intrauterine death, especially if diabetes is uncontrolled, because it's got this tendency of hypoglycemia. Once the baby is in the hypoglycemic milieu for a long time, suddenly becomes hypoglycemic because the mother didn't eat or anything. Then the baby just dies suddenly. Then the baby was alive, tomorrow the baby is dead. This is the condition where I said that in diabetic, the growth is asymmetrical. The head will be on normal size, and it can pass through a normal pelvis. The shoulders will be too large to pass through a normal pelvis, and you have got a condition called shoulder dystocia. What I discourage now is what we call stellar maneuver. Some people call it under pressure, where the midwives will, I'm on the bed, a big midwife trying to push the head down there, and that way it's causing palsy. Never do the stellar maneuver if you think the baby is big. You can only try to do it if the baby is not big and the mother is tired. There's poor maternal effort just to help the mother. But if the baby is big, do not do it, because if it's done, the shoulders are not going to pass through. They are going to hit against the pubic bones. And once they hit against the pubis, then you force it again. Then you are getting a situation where you are going to have a what you call palsy. And it's one of the commonest mistakes that the hospitals and doctors sued for, because if the child has got palsy, the rest of that child's life will be a cripple. She won't be able to use that other hand. If like this baby is coming here, the head is coming, and the shoulders are impinging on the quick bone here. If you apply Cristela maneuver, you push the baby, you're going to extend this. There's nerves that come from the neck, which are called brachial plexus. You're going to have brachial plexus injury, which is irreversible injury. Once you injure the brachial plexus, the injury is irreversible. And that child will have a condition called palsy. You can see this hand on the side, it's in a waiter's tip position. That hand is non-functional. And if a child develops a non-functional hand because you have injured the brachial plexus during delivery, it's an indefensible case that you won't be able to defend yourself why you didn't do elective Caesar. Because these nerves here, once they get overstretched, you can see the red, they get damaged forever, and they supply the entire hand. Then you don't want to cause Erb's palsy, because even occupational therapy doesn't. This is a child with Erb's palsy. This other hand is non-functional because of damage to the brachial plexus, which happened during delivery. It should not happen in the modern obstetrics when cesarean section is so safe. So these are some of the indications that I always tell you, that if they are there, and you explain to the mother very well, the mother is explaining very well, you should understand that this should be. You must warn that I have had a personal situation where, although we encourage that fathers must be there during antenatal and in the decision making, I think that decision must be secondary, because you might find that there's a father who says, no, doctors want to do cesarean section because they want money. No, deliver vaginally. By information, cesarean section pays less than normal vaginal delivery for medical aid. So there's nothing that to say that doctors want to get money because of cesarean section. So the mother, if well prepared, will agree, and the father, his role is to support the mother, must not come and take decisions, because He's not the one who's going to deliver, but he's going to be the one who's going to lay a lawsuit if anything wrong happens. We're preparing for a Caesar. If it's elective, we pay every day during antenatal. If it's emergency, we have to explain it immediately, the reason why it must be done by cesarean section, and obtain permission, consent. This time with human rights, also some of human rights were human wrongs in any way, you need a consent, which is a forced consent because there's no woman who can refuse, who is clever, who can refuse consent for cesarean section. But if she refuses it, then she'll take responsibility for whatever damage that can happen. But I don't think as a woman, if the doctor says, let's do a cesarean section, you should refuse. You will rather ask, what are the reasons? And then they're going to tell you the reason. And then you can discuss the techniques, the type of incisions that you want to do, the type of anesthesia that you want to have, which you discuss mostly with the anesthesiologist, who in elective cases will see you before you go to theater in the ward and discuss with you what type of pain relief, what you like. And then that way, the feeding option of the baby, if the pediatrician is there, you can discuss with him whether you want to breastfeed or you don't, or with your obstetrician. If you want to involve the mother, the father also must also be there as a supportive person. Fathers this time, they're very supportive, you know. I like them. They come to antenatal, they come. But when they come to cesarean section, some of them faint. That's why I make this presentation so that they mustn't come and faint here. We've got no time to resuscitate a father when we are doing a cesarean section. But I appreciate it. Fathers are very supportive. One thing that we must do, which is going to happen, is prepare for anesthesia. It's important that you, after everything is done, you're given an amnestic agent, a treatment, a tablet that will make you sort of not remember things, because it's not nice to go there sober. Go there, but they call it pre-medication, so that you don't remember things when you don't become scared, and it becomes easy because your blood pressure don't go up, you don't release catecholamines and adrenalines, then you'll be amnestic. You won't remember things very well. That will be done after everything is discussed and you've signed a consent. Often in elective case, you'll be examined by an anesthesiologist before you go to theater. In some emergencies, of course, in some situation, if there is around, he might come and see you before, so that he can prepare himself what kind of patients am I going to meet. But more often in an emergency, there's no time for that. You meet the anesthetist on the theater table. You are given a medication which is anti-acid, so that in case you have got reflux or vomiting, the acidic stomach contents comes into the mouth and you inhale some of them. It shouldn't cause Mendel syndrome. It shouldn't cause much damage. And I'm talking about those pre-medication that you'll get, which will make you amnestic. And then surgical side, if you're going to have, even if you're going to have up and down, but majority of Caesar have said we do it by beginnings incision, which is final steel incision. It will be shaved. It's advisable that you shave yourself at home before you go home for elective Caesar. But if for emergency, it will be shaved in the ward. And the intravenous line will be put on you. Then the drip that you are going to get will be the most painful thing that will ever have before. Because all other things that will be done on you will be asleep. And the aim of putting a drip on you is to administer the anesthetic agent, other medicine afterwards. And putting up a drip, a woman, depends whether the veins are visible or not. It can be sometimes be difficult. Majority of them, it's not very difficult. Most anesthesiologists and the midwives, and everybody can put up a drip. Actually, this is an intense job, put up a drip. But sometimes people complain that it took me many times. It's not because they're incompetent, because veins inside has got what you call valves. Sometimes you put it in the right vein, you don't know where the valve is. It hits the valve and it can't go further. You've got to remove it and put it on another side. But it's not very common that you'll be pricked more than twice. If you're pricked more than twice, you must know that there's a reason why you're pricked more than twice. Because the anatomy of your vein doesn't allow the drip to go there. Not every vein is quite straight. Sometimes got the valves there that will block, but majority of them will be put on the hand. And the hand that we put it on is the dominant hand, non-dominant hand, I'm sorry, the one that you use. If you are right-handed, your dominant hand is right, you put it on the left, so that the dominant hand can help you when you eat, the baby, towards when you are awake, you can use it. If you are left-handed, we recommend to use it on the right hand. Sometimes anesthesia differ, which you discuss with the anesthesiologist, which one you think is better. If you want to be awake when the cesarean section is done, better do what you call regional anesthesia, where they anesthetize only one region of your body, lower part of your body, where they're going to cut. The upper part is not anesthetized. Or sometimes called spinal anesthesia, which is a neuraxial technique in which the local anesthetic is placed directly in the subarachnoid space. The nerves, the spinal cord is surrounded by three membranes. It's the dura mater, arachnoid, and the pia mater. Just below the arachnoid, subarachnoid, there's a fluid that's circulating there called cerebrospinal fluid. They put this agent there that numbs the nerves from that area where they put it downwards, and is give a temporary loss of sensation in the area supplied by those nerves, which can last for 4 to 5 to 6 hours, which means after cesarean section, you still not be able to move your legs, not feeling pain, but after about 4 to 6 hours, you start becoming normal. When they do this, I usually don't want the husband to be there. I also don't want to be there. There are layers that the needle must pass through. The first one is the skin. After the skin, it passes through the subcutaneous fat. And from there, there's a ligament which is called supraspinous ligament, which must go through there. Just before the epidural space, there's another ligament which is called ligamentum flavum. It goes through that one. It goes through the dura mater, epidural space, dura mater, and subdural space. Then they are going to inject it between the subdural space and the arachnoid. Sometimes you can go into arachnoid space. Sometimes you can prick a vessel as you go through there, and that prick a vessel, the CSF, cerebrospinal fluid that comes there, it will come bloody, and it's not always pure blood. And the bloody tap, in the name for it is called xanthochromia. The anesthetist will just put a little backwards until you find a clear one. There's no need to repeat it again. It's because the needle that it went through here, it went through some of the vessel until it goes to the space where the anesthetic agent must be injected. And as I said, it lasts more or less 5 to 6 hours in here. And depending how you are seated, majority of anesthesiologists, they put it when you are seated. Some people can be put and when they are lying down, but in cesarean section majority, they put it in a sitting position because it's not very nice to lie there. And the preparation of local anesthetic is a sterile procedure. You don't want to inject hojas and bacteria inside the CSF, because if they go inside the CSF, it circulates and even goes to the brain. It can give a patient meningitis, and meningitis is a killer disease. So they will be draped, and the surgeons will have, their anesthesiologists will glove, and the area where they're going to put it will first be localized with the local anesthetic agent until they put a needle there and see the CSF coming and inject the agent there so that you mustn't feel any pain thereafter. It works more or less immediately after they finish the procedure. You don't feel any more pain, you feel numb, and then that's what the surgeon must do, assess whether you feel pain or not. So there are type of anesthesia that you might have. You either regional, which I've just shown you here, which is spinal anesthesia, or general. General is where you sleep. You don't see anything, you're totally asleep. If we explain to you, an anesthesiologist will explain to you what he's going to do. You'll be in theater, you'll be asleep, you won't be able to breathe. There's a machine which is called a ventilator, which make you breathe, will breathe for you. So in that way, the anesthesiologist will put a pipe through your mouth into the trachea, into the windpipe, so that can inject air and oxygen in the lungs. As you see here, this is the anesthetic nurse who's calibrating the ventilator. it calculates how much oxygen must you get, what breath rate must you have, all the physiologically breathing parameters are taken by that machine called a ventilator, which ventilates for you. And as it does that, all the other people everybody will be for himself. As we see here, we've got a scrub sister here scrapping and being ready, and the anesthetist is ready with the patient. We'll use the same drip that he used he puts on you, she or he will use it to the anesthetic agent. And then the other thing that must be done is that in theater, nowadays we do what you call defensive medicine. You must make sure that no mistake happens. The instruments that are going to be used, they must be counted. We know that we enter theater with so many instruments, we come out with many instruments. We haven't left anything inside the commonest thing that is left inside the patient's abdomen is a swab. That's why when the sister counts the swab, we must count it loud so that everybody can know that we entered here with 20 swabs. When we left, we have 20 swabs. Let's see. They are packed in multiples of 5. That's why you count only 5. Because this has been time when the sister is busy. The anesthetist will assess, after putting you under anesthesia, will assess the level of anesthesia, how deep you are. Some people can be anesthetic but can still feel some pain and other things. But it must be very deep in anesthesia so that by the time they cut, you don't feel anything. And they assess how easily is it for you to be intubated. You need a mask or you need a tube, because if the tube is not easy to access your windpipes, they might use a mask. Depending on the airway accessibility, that's the duty of the anesthesiologist that side, who will determine what kind of instrument to use to make you breathe. If you've got a short neck and they cannot see the vocal cords, some people will advise what method to do to make you breathe. Some people will just use a mask. The majority of people will intubate you with putting a tube inside there, back here. And that way, you see, with a laryngoscope, which has got a light there, he wants to expose the vocal cords. Between the vocal cords, if he puts that tube there that the nurse is having through here, then you are intubated. And that intubation will lead to air will pass through that to the lungs. This is successful intubation. There are certain tests that you will see whether the intubation is successful, like auscultation of the airways, and even the machine there can tell whether what air that's coming out of here is carbon dioxide or not. They call it a capnogram. It's very easy these days. Previously, it's just auscultation. Nowadays, there are more than one method of testing whether the tube is in the right place or not. And then as you are deep sleep, the anesthetist is always constantly there monitoring your vital data. He's the one who is saving your life in his hand. He's not even supposed to go to the toilet. Should anything happen untoward with the anesthetist not being present there, that's an indefensible offense. He has to be there. Some people will think the anesthetist is not doing anything. He's doing the biggest job. He's got the life of the patient in his hands, in her hands. As you can see, is the patient is having secretion, he's sucking them out so that he mustn't aspirate them. In the meantime, everybody's doing his job. You know, the sister is getting ready, putting the instrument ready, while the anesthetist there is making sure that the patient is deeply anesthetized. And the anesthetic nurse always help the anesthetist there with what the anesthetist might likely want, because if the anesthetist is not supposed to leave the head side of the patient, must always be there. On the other hand, the surgeon also must get ready. The surgeon, on the other hand, you might find that the surgeons are scrubbing. When you wash 3 times with either Hibitane or with iodine or scrubbing agents thoroughly. You don't want to take the hawkers from outside from your steering wheel to the patient. Scrubber must be thoroughly with running water, not repeating water. As you can see here, the scrub from there is not like washing when you are eating. Scrub from the palm of your hand up to the elbow. In that way, you become thin. You don't become sterile, but you become clean. And then when you put down the glove, you'll become sterile. So scrubbing can sometimes take a long time. Good theater sister will make a surgeon who doesn't scrub properly go and repeat the scrubbing, because as I've said, that the sister is the chief of the theater. This is the two assistant and the surgeon are scrubbing in here. And as they are scrubbing, anesthetist is doing his job, the sister is doing his job. And this is a multidisciplinary approach. It's sort of a coalition of Caesar. Everybody is doing the job for the same purpose, for the benefit of the patient. And then the surgeons will mop. When you dry yourself, you don't dry yourself like with a towel, as if you are mopping the floor. You just mop with a towel and throw it away, so that you mustn't expose more bacteria. And then you glove out and scrub. And everybody in the theater, no matter how many there are, everybody knows his job. Like you can see, as the surgeon is gowning, putting on a gown, which is a sterile gown, there's always a nurse next to her, ready to tie her up, because he can't tie himself at the back. This one is like he's got two nurses that are tying her up. The other one is left. And the assistant is coming again. It's also going to gown. And as they are all gowned, the area is regarded as sterile area. Doors are closed. Nobody opens the door for the bacteria to come in. And the cesarean section will start. So the operation is done under a very holy situation, which is well prepared for the safety of the patient, such that very rarely complications will arise. Put on the gloves for their benefit and for their benefit. Some people put gloves, some people put one glove, depending what they like. And again, you can see that the surgeon is going around so that it's scrubbed all around the back and forth. Then they can be ready for the operation. The theater situation. It's not a theater situation that you can go and observe and say theater is like this. That's why I present this, so that you can at least have an idea what happens in theater. What are the techniques? This incision that is made usually along the skin fold, whether it's fine and steel or sorry, more especially fine and steel. And the uterus incision is either made with a scalpel, which is a knife, or a scissor. I prefer a scissor. They expand it manually. Don't make a big incision, you just expand it manually. Once you make it, the presenting part, which is mostly the head, it's scooped out. If it's a breech also, you can scoop it out of the pelvis. And the body is either put on the mother's abdomen or on the thighs, between the thighs. You make sure that the baby doesn't fall, and clamp the umbilical cord. When the umbilical cord is clamped, you can cut it. While the baby is still attached to the umbilical cord, if the mother is alive, I mean, is awake with vaginal anesthesia, it's better to show the mother. Then it's proud that I saw my child while he was still attached with me through the umbilical cord. And you wrap the uterus and encourage it to start what you call placental separation. And then you can deliver the placenta without much pressure or much pulling. Just to see what to do. If the patient is draped like this, the only area that's exposed, the area where the surgeon is going to cut. And if the father has been prepared, I've shown the video, because I showed one of my patients all these videos. I give them on a test disc. And they know what to expect. There's no anxiety. You don't have a father who's collapsing. Then the surgeon will cut. It will differ. Some bleed a lot, some don't bleed a lot. There will be some bleeding. If you're alive, you will be bleeding. So It's not like the bleeding is torrential like Bukaro. Then they cut the skin, the scarpus fascia, the campus fascia, until they go towards the shield and cut the shield. That way, the layers that I've described earlier, going layer by layer until the surgeon knows that now at this layer, I'm likely to enter the abdomen. When he's likely to enter the abdomen, then he'll enter with safety. It is not just a blind ending. You don't know where you are. You must know exactly where you are at that particular point in time, so that you must know what to do and when and what to expect. The area that bleeds a lot is the skin and the muscles. If you inadvertently touch the muscle, but as I said, the muscle will separate them. There's so much bleeding that happens in a cesarean section. So when you enter the abdomen, I've said there are strap muscles which are called rectus abdominis muscles that we usually separate. The incision on the peritoneum, which is the parietal peritoneum, the last layer of the abdominal wall, it's not done transversely, even in infancy. It is done longitudinally, as if you have done longitudinal vertical incision, because it's easier to do it that way. And then the visceral peritoneum is the peritoneum that covers the bladder and the uterus. It's reflected, it's cut transversely like the skin, so that you can push the bladder downwards, because the area where you're going to cut is where the bladder is seated in a well-formed lower segment. Urinary bladder must be pushed downwards so that it mustn't be injured. And cut there where the urinary bladder was, so that later when you re-peritonize, the peritoneum of the urinary bladder can sit there. As I said, another advantage is that in a well-formed lower segment, bleeding is less and it heals very well. The incision of the lower uterine segment, as I've said, is lower transverse, unless you've got indication to do a DD or classical incision. And then from there, once you pass the skin, this uterine wall, got a fetal membrane. The fetus inside the uterus is covered by another bag of membranes, which is formed by two membranes called chorion and anion. They are matted together. Then those membranes beyond them is amniotic fluid and the baby. Then you can rupture the membranes and amniotic fluid will come out. Once you rupture the membranes, amniotic fluid come out, the baby will be visible. The one thing that you must be sure is that your incision is big enough. Even if you haven't cut the incision big enough, you can extend it by manually just pulling it apart, not cutting, because if you manually pull it apart, the skin can stretch. You can have a cosmetically small, nice beginning scar, rather than if you cut longer. If you cut longer, you're going to have an ugly long scar. You should just cut enough so that when you expand it, it's going to be about 9 to 10 centimeters. And when your skin contract, you're going to have about 4 or 5 centimeters scar in here. And one other thing, once you enter the abdomen, you pack the adnexal gutters. Why do you pack with straps there? Because amniotic fluid and blood, you don't want them to go inside the abdomen, inside the pelvis, beyond the uterus, because when they are there, they cause irritation, they cause prolonged pain, they might increase the chances of adhesion formation. So you need to wash. Even if you wash, you can't wash them all. The best thing is to pack area there and prevent them to go there. And every pack must have a tail. It's got a green tail. When you put an artery on that tail, because why you put that tail? I said the commonest error that people do is to leave a pack inside. You mustn't leave that inside. If you leave that pack inside, it's what they call an indefensible lawsuit. If you're sued for leaving the pack inside, there's no way you can defend it. And then when you count, of course, if you count, sub count was correct, that was done previously. When you count again, when we go out, we'll realize that we're missing a swap. And as I said, the sister is the chief. If your sister say, I'm missing an instrument, don't close the abdomen, doctor. Don't close. There's no way you can defy the sister. I've seen doctors who defy sister. You can't defy a sister. If he says, close. That's why when you close, you say, can I close? She must allow you to close. If the sister says, don't close until your instruments are fine, don't ever close, because if there's any lawsuit, he's also involved. That's why there must always be a leader in every situation. That's why today we have got a leader, a president. We can't all be equal. This thing of equality is just a way to say. In theater, we're controlled by the scrap system. It's the one who controls the ship of the theater. And if she's missing a needle or she's missing an artery or she's missing something, she says, do not close. You do not close. You respect her till she allows you to close, because to put them inside. Now is her pegs, and one peg is missing, one swab is missing. She says, I'm missing a swab. One way can be the abdomen. More often you find that it's on the floor or on some of the drapes, but she must make sure that everything is done properly and there's no instrument that is missing after cesarean section that she has done, because if that instrument is missing, she's the one who, the accused number one is the sister who must be accountable. Why is the instrument missing? Because it shouldn't miss. As we count and record everything at that particular moment, it's a very precise operation. That's why I've seen people play music, making a party in theater. In my theater, there's no party. We don't play music. We concentrate on the theater. Concentrate and we make sure that everything is done. People will say it's boring. It's not boring. It's serious. We're dealing with human life here. When you deal with human life, you've got no time to play games. Today, I think I'm on slide number 26. I'm just about to finish, but my PowerPoint keeps on stopping. I don't know, but it will come out. And then from there, after that, there will be cutting of the uterus and taking out of the baby. You would take out the baby. Must be another doctor who's called pediatrician who will look after the baby. That's why when you've got an invoice to say this is how much you must pay, there's always a pediatrician there. You mustn't say it's expensive. There are many people who are involved in delivering a baby, and everybody doing his own specialty. Assistant surgeon does his own specialty. Pediatrician does his own specialty. One thing that I've said, that's why I say it's a serious issue. There are also risk of cesarean section, which are medical-legal risks. If you damage the baby during cesarean section, or the baby develop what you call Bell's palsy, which can be caused by brachial plexus injury, like in that area where I discussed the shoulder dystocia that can cause Bell's palsy. Or the baby is deprived of oxygen for a long time, develops cerebral palsy. Or with a knife, when you cut the uterus, you cut the baby somewhere and you cause the baby. Leaving an instrument, like I've said, or a swab in the abdomen. And these are surgical complications. And sometimes there are anesthetic complications. Anesthetists might just give less oxygen than the baby wants, and the person has got brain function, and thereafter he cannot wake up because he was deprived of oxygen, or intubation was inside the esophagus, he is deprived of oxygen. But there are always methods to mitigate all those things. So all these things happen, we must try to prevent them, because nowadays people are very easy to sue if you don't do this properly. We don't encourage suing, but very few, if you do everything by the book, no lawyer will successfully sue you. Very few lawsuits are successful. Some few years back, I had a patient who had a cesarean section elsewhere. And after about 4 weeks, she came back to me and said, this is so painful. I always keep painful. It's so painful. I don't think the pain is not subsiding. Some people that I had Caesar together are not having as much pain as I am. I examined, I did a sonar, there was a vague mass, and I did an X-ray and found something like this. This X, the swabs that they give, has got a green, like color, which is radio opaque. If we take an X-ray, you'll find it. This is a swab inside the pelvis. We found a swab in the pelvis. Suddenly, it had not adhered, especially it had not adhered too much. We removed it laparoscopically, and I must say that we didn't even tell the patient what we found, because we protected the person who put it inside here. Because if we had put it inside here, angry lawyers will advise the patient to sue, but it was successful. As you further enter the uterus, you rupture the membranes and drain the amniotic fluid. And manually, as we've seen, you enlarge the abdominal incision, scoop the head of the pelvis out of the pelvis, because if the head of the baby it's already engaged, is deep inside the pelvis, but scoop it out to come suprapubically and be delivered easily and cut the umbilical cord. I prefer if the father is around, be the one who cuts the umbilical cord, because give them a sense of pride, a sense of ownership that they were doing something. And to cut the umbilical cord, it also, psychologists say, it increases the bond between the father their loves, and let him be the one who cut the umbilical cord. It is not a very technically difficult situation. After you have entered the head, you rupture the membrane, the liquor comes out, open the uterus, the head will just be visible. You see the head come visible. And if it's in the pelvis, you easily scoop it out with a hand. The father can cut the cord. I always ask them whether they want to cut the cord. But 90% of them will say no. 90% will end up cutting. Because when you arrive in theater, it's me who decide what you must do. Now, the baby immediately come, you mustn't aspirate, wipe it out, and suction if she's got fluid inside here. Over the shoulders without injuring the baby. You can have a healthy baby, a healthy mother, and the baby is put on the put the baby on the laps of the mother, and that baby went to the pediatrician. As I said, as a routine, let the father be something, and just be a sperm donor. Let him be something and cut the cord. Psychologically, it increases the bond between that mother, that father, and that child. It can even save the marriage. If my wife lived through a painful thing, these problems we have can make us separate. The father was cutting. And if the father cuts, you see, the father has cut the cord. Even when he goes home, he'll go and tell Majita, or no, I cut the cord, gentlemen. And then from there you can continue. It depends. Some babies, the head are not inside the pelvis. Once you cut it outside, just come out by itself. And you see that baby is delivering itself, nobody pushing it outside because it was not engaged. If it's not engaged, then it's easier to take it out and still suction the baby and clamp the cord yourself. The doctor will clamp the cord and ask the father to cut between. You see, the father with the chain, chain, the rich father. So that's what's happening in the cesarean section. You don't make it a game, but it make it something. If the father is involved, then it becomes better. Thereafter, you can deliver the placenta with ease. Before delivering the placenta, rub the uterus. It usually separates after delivery, and you examine the placenta both sides. This is the maternal side, this is the fetal side. And the membranes that I talked about, chorion and amnion, are here. You examine whether they are all out. You examine the inside the uterus, see whether those membranes, some of them were not left inside here. Because if they are left inside here, it might be a breeding ground for infection. The infection happens in the presence of the membranes there. It becomes very bad infection. And the placenta, the blood that comes out of the placenta is the blood of the baby. It's fetal blood. And if you want to take example for fetal blood, deliver the placenta, and give it there. The placenta, depending on the culture and belief. Some people believe that placenta, they want to take it home. Previously, before 1994, they would refuse. Nowadays, we agree that there are beliefs and cultures. Our cultures is our religion. If they think they want to bury this placenta behind the round double head home, just sign and take that placenta and take it home, because that's very which means it has to be somewhere with, but majority of them, westernized ones, they would say, I don't want to take the placenta. Then they can send it for inside. They're going to burn it. They call it incineration. They're going to burn it. Or they can give it to people who want to take hormones from placentas. But usually they don't take from hospitals. They take research centers. Then after you deliver the placenta, then you'll be suturing. Let me just summarize to you before I finish, step by step. You enter abdomen. These are the steps. Cut the wound. It's layer by layer. Small wound, bleeding, the assistant will swab, or if it's torrential bleeding, we clamp it. Second step will be at the sheath. That is right. Separate the strap muscles there in the sheath. You can extend it, but the extension of the sheath must be more than the skin, because the sheath is not expandable. After you reach the cyst, you'll find the strap muscles. Before you go to the strap muscle, there will be a peritoneum. If there has been previous season, like this one, previous season, you might have to dissect the peritoneum and feed the muscles. But in a pigeon abdomen, you don't have to do that step, because every layer is as God has put it. From there, cut further. After cutting the posterior lift, then you lift the peritoneum. Once you lift the peritoneum, we want you to lift the uterus outside, lift other abdomens, so that you can make a hole on the peritoneum. Once you make that hole, you can see
Dr.
the
Mahapa.
uterus.
Sorry, Dr. Mahapa.
Hello?
Sorry, Dr. Mahapa. We can hardly hear you now. There is somebody, I think they unmuted with their mic. It's making a hell of a lot of noise. I'm not sure whether it's only me who's hearing that noise or not, because we can barely hear you now.
It sounds like
Yeah,
sounds
it's
like
sort of like
rain.
it's like a galleon. It's like a galleon is going on, or a suction.
Okay, let me do like this. It's let me not share sound. It's this video. I took this video with my phone. Okay, let's continue.
Oh, okay. No, I thought maybe somebody was unmuted.
No,
But
it's
because we
this
could
video. I took it with my phone in theater, so it's got a sound like it's raining.
Okay, that's fine. You can continue, Doctor.
Okay, I didn't share sound now. I'm saying that if you cut the abdomen, you cut it just enough for the head to come out. If there's any extension of the skin, it's by manual stretching, because you don't want an ugly long scar. And then from there upwards, as you are at the level of the sheath, use a knife to cut the sheath, superficially avoiding cutting the muscles, because I have said the rectus sheath covers the muscles, because if you cut the muscles, it will be bleeding. And the extension of the sheath is through a scissor, because the sheath is always extended beyond the length of the skin, because the sheath, you can't extend it. And then from there, we have a peritoneum. In a normal, you don't have to do maneuver that is done, because this one was done cesarean section. The peritoneum is adherent to the undersurface of the muscle, so you have to separate it. But even in a normal situation, you don't have to do that. So peritoneum is always separated from that. In the peritoneum, you can lift it up and make a hole in the peritoneum after you have cut there. So let me. You can lift it. And I missed some of the slide that I want to show you. Okay, this is the peritoneum, that you make a hole in the peritoneum. After making a hole in the peritoneum, then you put a finger inside. You'll be seeing what's there inside the peritoneum. These are step by step for doctors who were here. And from there, if you have made that you are inside, you have entered the abdomen. Then after entering the abdomen, then you see the uterus. You have to now reflect the parietal peritoneum. Before you reflect, you pack the adnexal gutter, so that blood that's going to come out here and amniotic fluid must not go in there, because it will force you to try to suction or wash. And even if you wash, you won't wash it all because some of them will be in the paragolic gut and it increases the duration of pain and the chances of irritation and adhesion formation. So it's mandated that you must pack the abdomen. And the bladder, I've said that the way you're going to cut, there's a bladder, urinary bladder. The urinary bladder, you must remove it because it's sitting where you're going to cut. If the urinary bladder is, I like cutting the uterus with the seeds. Put the knife, a second. Not just damage the baby. That's why I told you that one of the physiological hazards is to damage the baby. So we don't want to damage the baby. If you have cut with a scissor, which is a blunt scissor, chances of damaging the baby are very, 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 very rare. And then you can extend the wound with knife. There are people who are not muted. Let me ask everybody to please mute.
One.
Let's mute, ladies and gentlemen.
126.
I'm looking, John, mute. John must mute your microphone. Who else? Okay, she was the only one who was muted. And as you talked here, and you don't mute, let me go back because he was making noise, that John. Abdomen, avoid of blood, either left artery there at the end of the tape so that you mustn't by mistake leave that. You mustn't by mistake leave that top inside the abdomen. Then from there, the reflection of the bladder. We reflect the bladder away from the where it is, and we cut the uterus, the lower segment. If you said term, you will form. Cut it with the scissors. I prefer scissors. Some people prefer knife, but the blunt scissors, we never interpret this because it's so thin. Quickly reach the area where you find the baby. Then you can divide very easily. Scoop it outside. If it's inside the pelvis, you have to scoop it out. If it's selective, usually maybe engagement is not so deep, you don't have to scoop it outside. That way, it people can come out with something. It doesn't go inside the abdomen. Complete the area where it can flow into. In this one, we again have the near there was a cord around the neck. It's an umbilical cord around the neck. That cord goes around the neck once or twice. It can kill the baby because if the cord is around the neck, it strangulates the baby. The cord around the neck, the baby is anti-cancer. But sometimes it happens that when you don't see the cord is around the neck. When the baby is twisting and getting inside, the cord, it is around the neck to strangulate the baby. But this one is only going half half a second around the neck. So if the baby is twisted against that, there's a possibility that it can strangulate the baby. Buccal cord, you can diagnose it ultrasonography, as I said, during pregnancy and see that the cord is around the neck. And if there's a cord around the neck which has gone 160 degrees, the best way is to do it elective caesar because you don't know what's going to happen when the baby comes out during delivery. You don't want the baby to die during delivery because cord strangulated the baby around the neck. I had a situation, a story that I want to tell, that I had a woman who delivered some years back, still in Pretoria. She had infertility. Treated her for infertility, like she got pregnant. And at about 36 weeks, I saw this picture. cord is around the neck. I said, no, we have to do a Caesar today. She said, no, doctor, we can't do it. Go mute. She said, doctor, we can't do it. Why? You are not the only doctor who was treating me, because we are not the only doctor who are treating pregnancy. If somebody is attending pregnancy here, you must know there's also another doctor at home who is attending to this pregnancy. It might be doctors, other doctors. You're not the only doctors. So that woman said we must do ABC before delivery, otherwise this child won't survive. I stand in a country because I can't say that woman is not talking facts, because should anything happen with this baby with a nuchal cord, he will say, told you that there's my doctor or family doctor who's looking after my children and everything, who said we must do these things, who's a younger doctor. And then can't the younger doctor come to the hospital? He said, no, he can't come. And then they'd come tomorrow. And he went home to go and do whatever he does with the younger doctor. Tomorrow morning when I came, this is what I delivered. The cord was 4 times around the neck and the baby was dead. But it does get to keep quiet. I can't say the young doctor was wrong or what, but that's one thing that you must know, that if there's an emergency to be attended, like nuchal cord, it must be an emergency, and it can be seen ultrasonographically. There are many pictures of nuchal cord that I've seen that, if not attended, they lead to the cord going many times around the neck of the baby and strangling the baby and causing the baby to die. And losing a nuchal cord is easy, especially with 2D ultrasound. Even on 3D ultrasound, you can even see it around the cord and do a Doppler of that area and see that there's an umbilical cord around the cord. So umbilical cord around the neck is an indication for emergency Caesar if it's a term, because it's visible on ultrasound. See, this one also has umbilical cord. People, when they go ultrasound, medical aid says they pay only for 2 ultrasound. Doctors do many ultrasound. You have to do ultrasound every time, because you don't know when calamity is going to come. You don't know when you are going to meet a situation where a cord is moving to go around the neck. You don't know when you're going to have a nuchal cord. You see this one, the baby's hand is holding the cord with their hands. Many times, every time the baby comes, there's something that you are looking for. People, when they do a sonar, they just look at, they want the beauty of the face, and they want the gender of the baby. The sonar is not for gender. Mothers will ask you, what is the gender of the baby? As if the gender of the baby. It's good to know that it is a female baby, but it's not of much medical significance whether it's a male. You can't change it. It will remain, if it's a female, it will remain a female. If it is a male, it will remain a male. The main thing is that these are male, female baby, which most people want to know. But the reason why I'm doing many sonars is to look for things that might happen, which were not there the previous time, like nuchal cord, and so that action can be taken. So unfortunately, some of the sonars that the medical aid doesn't pay, you have to pay for yourself. But it's not because the doctor likes sonar every time. That's why you go for antenatal care. It's continuous monitoring of problems that might not be there or might not be there. So the other things that can be seen, sonar can even diagnose congenital abnormalities like the spina bifida. You can see it in here in the spine, there's an occult spina bifida. If told enough time, then if you are told early, then you can know what to anticipate, and a neurosurgical arrangement can be done early. During that cesarean section, what's the role of the pediatrician? It's to look after the baby. He's going to look after the baby until 12 years. He resuscitates the baby, because in a normal vaginal delivery, either the doctor or the midwife will resuscitate the baby, but there they are operating. So this is given to the pediatrician who will examine the baby. The first thing that they do, they put it on the scale, measure. That's the birth weight. Birth weight is the weight immediately after the cesarean section, before they can even birth the baby. Weight after 20 minutes is not a birth weight. It's 20 minutes weight, because once you still have fluid there, she's got venic caseosa. That's the birth weight. After weighing, then they're going to examine her whether she's got congenital abnormalities or she's other things. They do motor reflexes, developmental reflexes, tell you so that it is easy to be told this is how the baby was born. If everything is fine, they note it. So that should anything happen thereafter, we know that this was not born with. This happened after birth. And the majority of babies are born with good things. In the meantime, as the pediatrician is working there, the surgeons will be suturing the uterus and finishing. Usually by the time the pediatrician finish examining the baby, the surgeon has finished suturing the uterus, but they will leave the surgeon to finish everything. And as I said, it is done step by step. A normal cesarean section will take a slow surgeon about 45 minutes to 1 hour. A quick surgeon, 30 to 45 minutes. Any surgeon who says I finish Caesar in 20 minutes is skipping other layers, which is not a good practice. You mustn't skip any layer. There's a tendency this time to not to suture the peritoneum. I'll show you what side effects thereof is. Even in the literature where people say don't suture the peritoneum, we have reached a stage in literature where they're deteriorating. There's no improvement. People are advocating things that is not to be done and are proven to be good. Just because of being different, they say there's no need to suture the peritoneum. There's a need to suture each and every layer as God has been. You must continuously suture layer by layer. You either use interrupted stitches or continuous stitches or subcutaneous, but each layer must be by layer. The skin, it doesn't matter what material you use. You can use staples, you can use clips, you can use suture material, but things as you find them. If some patients, because nowadays women, black women, if they get fat, they really get fat. You the pressure bandage so that there mustn't be seroma, because fat, with fat necrosis, you get fluid seroma in between, and it can give a dead space. And if that fluid get infected, the abscess that is there, you don't want to, it's not easy to treat it. And if you suspect that there can be an infection in a thick abdominal wall, you can put a drain there for some time to drain that seroma so that you can have a cosmetic strong scar. The aim is not cosmetic, it's strength, but cosmetic is also appreciated. And as I said, layer by layer, there will be inner layers that you must stitch. The stitches can either overlap, it can be one stitch from one layer to another layer, but this is the skin layer. The subcutaneous fat layer will be stitched separately until you have a nice one. By the time you reach the skin, you have done 3 or 4 layers before you reach the skin, and they finish up. Nowadays, they finish up with a final stitch, a subcutaneous stitch, which gives a cosmetically beautiful scar earlier on. But that's not a guarantee that the scar will always be beautiful, because it depends on how you heal. Because acute and chronic inflammation, because the way it heals by recruitment of acute inflammatory cells and chronic inflammatory cells, you might find that the scar that was initially very well, when it starts healing, is wider like this. Depends, people heal differently. If you put a wide scar, it doesn't mean the doctor didn't do well. And some scars become hypertrophic with raised borders. And some people, usually Africans, they develop the type of scar called keloid. Even if the stitching was very, no matter how it is, if you are a keloid former, you're going to form a keloid. And if you remove a keloid, another keloid will form. Or if you're a person who's going to have hypertrophic scar, you'll have it. If you've got an ugly scar, it's nobody's mistake. That's how your body heals. Recruiting fibroblasts and forming hypertrophic scar, or to develop keloid by yourself. Keloid, if you remove a keloid, another keloid is going to form. You remove it, another, it's a nightmare for plastic surgeons to do it. We should send them to plastic surgeons, but I don't think they like us to send to them, because there's very little they can do, because they don't control how you are healing. The majority in gynecology is subcutaneous, you stitch the skin with subcutaneous, tissue-friendly in each material. In that way, chance of irritations are less. And one thing that I must say, we avoid using cautery, because cautery is fire, has got a thermal band, and the thermal band extends beyond the area where you're seeing. If a person is a keloid former with a thermal, with cautery, it will be like a keloid of band wound. Keloid of band wound becomes very huge. So, but if that way you can be able to minimize the chances of keloid formation. You can never stop them. You can minimize them. I say minimize. You can't prevent them. If you are a keloid former, you'll be a keloid former. We just wish if you heal very well, you heal without formation of keloid. Then you can have a nice bikini skin, which when healed will be like this, and it is within the hairline. Nobody can see it except your partner if he wants to see it. It's better to have cosmetic when dealing with women because women are cosmetic creatures. So I said step-by-step closure for the abdomen. I want to show you. This is the peritoneum, which I said many people don't close. Close it. The doctors have it, please close it. It won't take much of your time. It will just add 2 or 3 minutes from your time. Close it because it minimizes the chances of adhesion formation. I'm not saying it prevents adhesion formation. You can never prevent adhesion because nobody even knows what causes adhesions. But because it's a barrier between the abdominal wall and the uterus, the chances of abdominal wall adhering to the incision of the uterus become less. And stitching the peritoneum doesn't take much long. So the notion that it increases operation time is neither here nor there because 2 minutes increase in operation time is not something that one can worry about. It will be 2 because it will be about 3 to 4 stitches that you put there, which are not tight. You close the peritoneum. Close both the visceral and the parietal peritoneum because I'm just going to show you what complications we meet these days because of the tendency of not closing the peritoneum. What complications we meet here, which not everybody can manage. And they usually come to us urogynecologists with frequency of urination. If we close the peritoneum, that's next thing that you must close, approximate, is the rectus muscles that you have separated. Approximate them tightly, not tight because they can be very painful. Just approximate them so that the woman must not later have a hernia between them because the muscles that are separate, you'll have divarication of the rectus muscle. When she coughs, it's like she develops a hernia there in the abdomen, which is not nice. So we just approximate them, not sit them tightly, and then thereafter, the patient will have a good abdomen because this patient still wants to have good abdomen. That's why they always ask, although that thing doesn't help any much, it's just psychological. I just say, warfare. Oh, I know that there's nothing warfare will do. You don't do bad, it won't do good. So you suture the peritoneum, both parietal and the visceral peritoneum. Let me go here. The subcutaneous skin, why you suture it? You are avoiding the space. Dr. Mahapa, you keep on unmuting. I ask you to mute, you keep on unmuting. I don't know why. Please, maybe it's your child that unmute you, I don't know. To avoid that space there, the subcutaneous skin in the scapus fascia and campus fascia. Avoid formation of a dead space there. Suture with 1 or 2 layers there. Once you suture with 1 or 2 layers there, you will avoid that dead space. You know what, let me request. If you keep on unmuting, to compete with my PowerPoint, my PowerPoint does freeze. Manu Kumaredi, please mute. Mute.
Am I right now?
I ask you to mute, you are muted. My PowerPoint cannot, my memory of my CPU is not very high. So my PowerPoint, it keeps on freezing. Then, when you do speak function, let's say, that's approximate. Not to avoid the formation of dead space, which if we can have better stoma formation, it will give you a fluid there. if that food can get infected, abscess does the answer. Be very careful. And if it's very big, it's advisable to put a brain there because if that there always be infected process. But if you put a brain there for 3 days, that is a normal brain. Then we get a dry subcutaneous which is very weak. When it is very big, 1 to 2 days, you go and open up after 72 hours, when that fat is really not there. So fat is big. So reservoir plates and plate is big suture material. And after if you approximate it like that, then you can do subcutaneous. Here is the second layer of the fat that is stitched in the same one. This fat was when the skin fat was subcutaneous fat was very thick, so we made it in 2 layers. But usually women are very thin, you can make them in 1 layer, and then after you those subcutaneous makes nice material which I said it does not guarantee that this guy will be it depends on how she's going to eat. Whether you put steroids there, you put all the medication that they just the same as food. It's not a guarantee. If you are a keloid form, I'm going to remove you. Because one thing I can do this side is to remove somebody from there. I don't want
It's
to
on mute.
Ready, please. Yeah, thank you.
Am I okay now?
No, yes, you still are muted. Mute, please.
I'm still unmuted.
Yeah, I'm muting you, ne? Don't unmute. I've muted you. We are unmuted. Just mute. You'll see your microscope, the microphone there will have a mute.
Okay.
Mute, let's see. You're still unmuted.
I'm still unmuted.
Okay, let me mute you. I muted you. Please don't unmute. Don't touch anything. Very well. And I said it's not a guarantee for a baby's car. So when the people car, don't blame your doctor. It's you the way I give, especially the people with a lot of collagen layer, like people, melanin, they heal very bad. So actually it's better in 15 days. Beautiful scar, because women, they sell their beauty. If you have got a beautiful car within the hairline, better. Some people they heal so well that you can never know whether they had a seizure or they didn't have a seizure. The common complication of incorrect abdominal closure, a leak, skipping other things, cutting corners, is wound dehiscent. The wound will just dehiscent, separate, and form adhesion between the uterus and the anterior abdominal wall. Those are the common. If the wound breaks because either suture material is not good or you didn't suture all the layers and the patient coughed, then the scar is going to be bad and you have got to increase the morbidity of the patient. Sometimes you can hit these completely and you see the uterus. It will be worse in a situation where adhesions happen and around wound test, what we call evisceration care. The intestine comes out of the wound when the patient coughs. And by that time, she's at home and see malaria because you cut corners, you didn't stitch all the layers all together. You just stitch the skin or stitch 1, 1, 2, and you say, I finished the scissors in 15 minutes. This is the complication that is going to happen, which is a grave complication. Take your time. Show good abdominal wall stitch. Good strong stitches. Suture the visceral, the parietal and peritoneum separately and minimize the chances of adhesions. This, as I see here, it won't take just tell the story of anybody. These people who are allowed to take part in life. Even if they want to do it quickly, there's no hard. never bother. It's about good, but take time, do proper things. It's not a marathon. Don't show somebody. You don't get a mental condition. Have complications that get fine. I am going to go back to spend more time correcting these complications. Your education change. It's better to take time. As to show you how long it takes to use the peritoneum. I finished. So why people are doing one of the complications I say, if you don't suture peritoneum, you've got separate the adherence of the uterus to anterior abdominal wall. These patients, I've seen more than 10, and I'll always do it because they come to urogynecologists with a problem of frequency of urination. Because the bladder cannot expand. And then we ask it, we urinate how much volume? Very little volumes, because once the bladder contains about 150 to 200 mils of urine, it's full, because it can't expand anywhere. The uterus is adherent to the anterior abdominal wall, and it sort of aids the bladder there, constricted the bladder in that constricted area. This is one of the patients that I've seen, and I always see men. When the patient says for frequency and the urine test, you do a urine dipstick or a culture urine, there's nothing, you do cystoscopy, you find a small bladder volume, you do laparoscopy, you find such a thing, and find that she's previous Caesar. Then if you ask who is this, it won't be a young doctor, it won't be an old doctor. The young people, they like corners, don't like corners. There's no shortcut in life. Do things properly, then you will see everything will be done. Let me show you when we have to deal with this complication, what are you likely to meet? This complication, you can deal with it laparoscopically or through laparotomy. If you have to do it laparoscopically, you must be good in laparoscopy because you don't have that three-dimensional appreciation of where the scar tissue is, where the bladder is. But at laparotomy, it is for that tactile sensation, you can put your hand there and see that, okay, what I want is here, this is the bladder. If uterus is adherent to anterior abdominal wall, the procedure, what I usually do is what is going to happen here. What's going to happen here, probably it will come back, probably one of the people is unmuted, but my PowerPoint is slow here. No, that's coming. If you enter through a laparoscope, upon entry, you'll be surprised what you find. Usually, because of your experience, I know what I'm going to find. But when you go inside, you find that the uterus up there is adherent to the anterior abdominal. And that adhesion is a dense adhesion, which you cannot. There are dense adhesion which are strong, and flimsy adhesion which you can just separate with the forceps or any instrument that you are using, whether Babcock or anything. But if it's dense, you need a scissor or maybe cautery, cut it. This type of adhesions, they are very strong and dense adhesions. The bladder is beyond them, and the bladder has got no area to expand to. Hence, the patient complains with frequency of urination. Every 1 hour he goes to the toilet. You can see that area which is adherent is very dense. And if it's very dense like that, the only way to deal with it is to teach with the Caesarean section. And because it's laparoscopic, you've got only two-dimensional view. You don't have three-dimensional and tactile stimuli. So you really have to be very slow until you reach the area where you think a bladder might be, because otherwise, inadvertently, you might just cut the bladder. But I don't think I've never cut the bladder with it because I go very slowly. As I said, with surgery, pretty much sure. But this uterus must fall down. It can't be on the anterior abdominal wall. This is anterior abdominal wall, this is the uterus. And you cut in between and separate. More often you go towards if there's bleeding, you can just cauterize it. No, there's never a big bleeding. Cauterize it, it stops bleeding. Never big vessels. But stitch by show, one by one, go until you reach the area of the bladder. This operation will take you 1.5 to 2 hours. You were doing a Caesar, which was going to take you 45 minutes. You shortcut. Now you're going to do an operation of 1.5 hours until you reach an area of the bladder where you'll see the fat around the bladder. Then you know that the bladder will be coming. This starting layer there is the bladder layer, outside layer. Or if you want to test whether this is the bladder or not, you can feel fluid inside the bladder through the catheter, and it's still the fluid inside the bladder. It will distend. You see where the bladder is, but here it's visible on that fatty layer. And this, during filling phase of the bladder will be able to expand. So a human can carry about 400 to 450 mils. You know, a female bladder can carry about 400 mils to 450 mils. A male can carry about 450 to 500, a bigger bladder. But a woman must not go to toilet every 30 minutes and go to toilet and pee only 120 to 200 mils of urine. It's because the problems that were made in the cesarean section, which because the shortcut is not good in surgery. You always do the proper things. Always take your time to avoid this problem of uterus adherent to the anterior abdominal wall. You can see here, if we distend the bladder will be distended. During the filling phase of the bladder can accommodate more. And if there's any bleeding, bleeder side, just cauterize them. But with time, as the patient is encouraged to keep training, drink more fluid, to delay going to the toilet, those ligaments that are there in adhesions will expand, and she will be like any other woman who has got a normal capacity uterine bladder. This complication is a complication of cesarean section, shortcut in cesarean section, which I discourage very much. That please suture all the layers. Don't go with these journals that say may not suture. You go to a congress, you find a whole professor saying you mustn't suture. You mustn't believe every printed word in the journal. There's a lot of rubbish that's reached reputable journals. So I think in conclusion, ladies and gentlemen, this is what I'm trying to tell you. This is just to expose you to procedure of cesarean section, so that you can have idea. This was meant for a layman. It's not, although it's good for doctors to know, for lay people, because my presentation are usually public presentations. And the message you take home, take time, a proper operation. Don't rush. Somebody, don't rush. And people rushed. Now they're very tall. Don't rush. Last week, some people was telling people, don't rush. If you rush, you get into trouble. And people didn't listen to him, rushed. Now they'll be in trouble for the next 5 years. So you are not rush during the cesarean section. Take your time, get proper things. You rush, we are likely to leave the swabs inside here and everything inside here. Don't rush. Just do a proper job, proper operations, then you'll know. I think this one has opened the eyes of the doctors who are here, who are my colleagues, and opened the eyes, and as a enrichment public health education to the lay people who are in here, who their wives or they themselves might deliver by cesarean section in future, and they know what to expect for the cesarean section. There are various methods of doing. It's not the gold standard of cesarean section, but it's more or less what is done. Because many people do things differently. The variations are not very gross. There are always variations of doing the same thing. But more or less, these are the steps that I thought in this time that I have, it's what cesarean section is all about. You've got an idea what it's going to be. If they say your brother, your mother, yourself, your sister is going to have a cesarean section, you know what she's going to go through it. For husband out there, you know what your wife goes through when she gives birth to a child. I don't think there is any reason that you must use to offend the person who brought you a baby with that horrible and painful operation. It also increases the bond between the mother and the child. That's why I always say, fathers are part of pregnancy. Pregnancy is not only the woman who is pregnant. The woman and the father are pregnant. They must always be pregnant. And I think this has opened to prepare. If you've got any questions, I'll soon take questions. And I saw Dr. Mlauzi here. I'll want them to, as I said, it's not a blueprint. Many people do things differently. We might differ as gynecologists. He may also add some comment, and then but there are other doctors and gynecologists around here. You're welcome to augment and comment so that you can enrich us. Because this is just a public education endeavor, not for any financial gain. There's no CPT point. Just because I'm an old teacher of medicine, I've got so much data that I don't know what to do with it. I can't go to grave with this data. Let me just share it with the people mahala. Because I don't buy this data that I have. I have it. I've been working for the last 40 years in obstetrics and gynecology. So these things I can just share with you. And from there, we will open the avenue for questions. You can see there, I take my time when I do things. I'm not in a marathon to say that I'm a winner. There's no winner. Winner actually is the one who does the proper job. The one who does quick is not the winner. Ladies and gentlemen, thank you for your attention. And we can have discussions, questions, augmentations, other things that we can have now. Thank you. This is the end of the webinar. Let me unmute you. I want to unmute you. I want to allow you to unmute yourself. I did allow you to unmute yourself. You can unmute yourself, but when you want to talk, you must raise your hand. Like I see, Njenge is a gynecologist, an obstetrician gynecologist here in Polokwane. I'll allow you to talk, Njenge. Raise your hand. I'll see you here. When you raise your hand, you go away. I don't know. Njenge, how do you raise your hand? Just educate us. Go to reaction, eh? Njenge, talk. Dr. Mlauzi?
Sorry, you
Dr.
muted
Mlauzi, how
us,
do you raise
Mister.
your hand?
Oh, Dr. Mahapa, can you hear me now?
I
You
can hear
raise
you.
your hand where you mute or unmute. When you press it, you can see raise hand, mute, or rename. That's where you can raise your hand. Where there are participants, you just go and click at your name, and then you will give the option of raise hand, mute, or rename.
Okay, now
I'm pretty sure the junior doctors, they should be able to know it.
okay.
Maybe Dr. Mahapa, you can just give it a luxury that if ever you don't know how to raise your hand, you can just talk or say something
you
while
can
you
just
are.
introduce yourself and say, I'm Dr. and Mr. So you talk. Thank you very much.
Okay, thanks, Dr. Mahapa. It was nice.
During the op, but bowel injury shouldn't occur in general. However, we do see it, and we should be saying to ourselves, when you enter, be careful that you do not have the bowel adherent to the previous scar, particularly the midline incisions. And I think I'm very happy with what Dr. Mahapa has emphasized, the anesthetic part of it. Now, Minister Mutsualedi used to ask me, I was in the maternal death committee chaired by Professor Moodley, and we used to have the belief, you and I in the olden days, we used to do a lot of seizures under general anesthesia. There were less maternal deaths, anesthetic related deaths from anesthesia versus spinal. And the minister was concerned. We keep on saying in literature, spinal is safer versus general anesthesia. And I used to tell him that indeed research shows, but where there are complications, it also goes with a degree of training. So those are very important. Should we close the peritoneum? I like what you have said. I've seen about 3 or 4 patients recently where the bowel has herniated through, where the parietal peritoneum is not sutures and the bowel has herniated through. Now, in one patient, I had said, we are going to repair elective. The registrar got angry, sent the patient away during the weekend. The following week, when she presented, indeed, there were complications now to the bowel. So it is important to emphasize, although literature still emphasize that do not suture the parietal peritoneum. Exteriorizing the uterus during following delivery of the baby. You remember Prof. Marivate used to always like this question. Should you suture the uterus while in the abdomen in situ, or should you exteriorize? And he always made pros, against, and for. And I think it's a matter of, one, what are the indications? Two, do you find there are problems during the procedure? Three, if you are to perform sterilization like bilateral tubal ligation, can you do it with the uterus in there? More often, you have to take it out. And lastly, is just to complement the points that you have raised and we need to be cognizant of. Thank you once more, Dr. Mahapa, and thanks for colleagues who have endured the night to be part of this discussion. Thank you.
Thank you very much. I appreciate that when I've got comments and other things. There's Dr. Mtlari, Dr. Chokwe, Dr. Moko that I've seen. Unfortunately, with time, we can not all comment. We can talk the whole night about cesarean. Ladies and gentlemen, thank you very much for honoring this webinar, which I do every month except December. So I do 11 webinars per year. I'll stop the webinar here. Thank you very much. I appreciate that. The